Objective A is to understand how to treat it. So when we're all done diagnosis, you still have to treat it. And if it's the majority cause of dry eye, then we want to treat the meibomian glands, obviously. But the treatment could be palliative or restorative. Our goals could be to stop evaporation, provide lubrication. But again, I go back to it. Ultimately, we will be with the dental model for prospective prevention rather than retrospective reflection on the agony that individuals have that we cannot ameliorate. Now, one of the treatments, of course, is lipid eye drops. And because at the Academy of Optometry, I was made very clear that we should always mention every time we have a financial interest in anything. And I was the inventor of Soothe XP 100%, and when that was in the market, I did receive royalties through a company. Sustained Balance is on the market. I invented 3 or 4 parts of that, and I do receive a royalty to a company. I do not receive a royalty on Refresh Opti, which is also a lipid drop. The utopian adjuvant that you can put on the eye can never replace the miraculous wonder of every blink that's appropriate, providing lipid into the meniscus and onto the tear film. Just think about it. I mean, incredible system, an incredible system. So again, if you want to treat it, there's always an epithelial overgrowth. And you know, Jim, we're talking about debridement. Here's a slide from 1977. I've been lecturing on this since 1977, and I never could, and the next step never came to me. All those years. I mean, it's just really incredible. So our first step is to see if we can eliminate this obstruction. Now, that obstruction is not easy to eliminate because how many of you really understand filamentary keratitis in the room? Very few people do, but filamentary keratitis is epithelium, which is shed. It's desquamated for various reasons, and it then just rolls up, and it can even have a nice proud ball on the end of it. Well, that problem of filamentary keratitis is exactly what happens inside the gland, because these glands, the terminal duct, should be lined with a type of self-cleaning epithelium, but it's lined with keratinized squamous epithelium. And I don't understand why, except for structure, but if that is inadequately cleaned and the muscle myelin doesn't keep that clean and keep it expressed, it just begins to clog, and you get these filaments come out, you get keratin which comes out, and it just forms a plug, a real plug. And frequently, no matter how hard you squeeze, it's virtually impossible to break that out. Hopefully we'll develop imaging so we can conduct more sophisticated studies on it. So the way we treat MG function at present, the patient treats it with warm compresses, with lid hypothermia. And many people advocate massage. Don't ever massage to your lids because that's one of the best ways to develop keratoconus. If you want to squeeze, just have patients squeeze that way. Squeeze as hard as they can. They won't do any harm, and that is modestly effective. And then lid scrubs, as we said, right on top of the meibomian gland orifices. Warm compresses are great, except for the fact they have to be done for certain at the time, which I'll show you. Now, professional treatment involves forceful expression, and we have published on the results of that. The problem with forceful expression is that it's painful, and it's a great way, as we'll show you, to monitor your practice growth. Now, inner eyelid surface temperature, if you use warm compresses, the question is, how warm do the meibomian glands really get? If we look at a warm compress placed on a research basis where the warm compress is kept at 45 by a team of people measuring with infrared, the temperature on the outside of the lid goes up to 42 degrees very, very quickly. It just gets there very quickly. Therefore, a 1 or 2 minute warm compress on the outside of the lid is a very effective method of getting rid of the scurf and the blepharitis and the desquamated material on the outside of the lid. But on the inside of the lid, it's very difficult to get up to 40 degrees, very difficult. And that takes about 6 minutes. of keeping the compress at an optimal temperature. So that's the problem. We've also published with Charles McMonnies from Australia on how the use of warm compresses can exacerbate a corneal irregularity and end up with various magnitudes of keratoconus. It can actually induce keratoconus. So if you're using warm compresses in individuals like we do for 8 to 10 minutes at a time, you really have to do a corneal map at 3 months, at 6 months, and then at a year, and then certainly every 6 months, because you can be developing non-refundable, let's say, permanent types of corneal changes which compromise vision. So the summary is you have to recognize the problem as obstruction. You diagnose meibomian gland functionality by diagnostic expression with a standardized force to mimic the forces of a blink. You can treat obstruction. The patient can with warm compresses and self-expression and scrubs. In the office, you can treat it with forceful expression, but pain is the limitation. The premise which we're proven is that a gland which is not functional can return to functionality. Treatment by drugs, I have never been able to demonstrate that it returns the gland to functionality, whether it's doxycycline, whether it's Restasis, whether it's azicite, whether it's anything. I have never been able in any controlled trial to demonstrate that I can open glands and return them to functionality. Perhaps other people can. There's a treatment which maybe we should talk about. It is I&I. One of the residents passing through said, oh, I&I, inflammation and infection. And you can treat them with drugs, obviously, as indicated. And there's other methods, ductal probing, intense pulse light, and LipiFlow, which have various degrees of success under various circumstances. Meibomian gland expression itself has a long history starting in 1888. But again, recognizing that the primary problem is obstruction, in 1994 we published, myself and Jack Greiner published a paper on treating a group of people with forceful expression in the office monthly and measuring what happened, and both functionality went up, symptoms went up, and lipid layer thickness went up. So it is effective. It may not be the best, but it is effective. But the pain tolerance is relatively low, and whenever you apply pressure against a hard surface, it's very unlikely that you will not experience significant pain. Even if you use a topical anesthetic, even if you use lidocaine 8% on your jojoba oil, the pain level with topical anesthesia, tolerable is between 2 and 4 pounds of pressure per square inch, marginal between 5 and 9, and significant pain after 10. And we built an instrument which allows us to evaluate that. Some of you who have been in my office have seen us do it. But in a study that we did, only 21% of patients could tolerate the forces necessary to achieve therapeutic expression. And the amount of force that was necessary without heat was 16 psi with a big range. And if you really wanted to therapeutically express every gland in the lower lid of both eyes, you had to start getting up over 30 psi. And if you look at the amount of, it just isn't tolerable, because the minute you go over 8 or 9 pounds of pressure per square inch, it is not comfortable and it isn't tolerable. And one of the methods, if we all have patients who would really be better off in the care of others for various reasons. Maybe they're not totally happy with us, maybe they're unrealistic, maybe they disrupt the office. We could go on and on and on. And I guarantee to you that if you prescribe a program of biweekly forceful expressions for them, that's the most effective method for getting them to better understand the problems that they suffer from.